Hi everybody. Here I am going to take something on pediatric malignancies. We are going to discuss about case-based scenarios as well as picture-based scenarios, so that it will help you to remember so many things instead of mug up certain things. So okay, I am Dr. Sharat Balaji, working as senior assistant professor in Madras Medical College in the Department of Pulmonology for the past 4 years. And let's go to the first question, number one. And here is a 4-year-old fever for about 4 weeks. The child is on multiple antibiotics, but there is no response so far. And the child is having an associated hepatosplenomegaly. Pallor is present, red spot is present. The child is complaining of nocturnal pain. The child cannot identify where the pain is. And while doing a marker, it is positive for PAX5. So what is your diagnosis? Is it B cell ALL, T cell ALL, AML, neuroblastoma, CML, or something else? So when do you suspect malignancy? A malignancy should be suspected only when there is involvement of more than one cell line. So that is involvement of bone marrow. See, for example, this child is having fever for about 4 weeks, not responding to multiple antibiotics. So you need not think about an infection here. So always, if two set of antibiotic doesn't work, you need to think about a third diagnosis, which should not be a infection. Rather than, you should consider either a autoimmune disorder or you should consider a malignancy. So this child has not been responding to our antibiotic. The child is having hepatosplenomegaly, pallor, red spot present. So what do you mean by pallor? That is involvement of RBC line. Red spot in the is in the skin. So it is more in favor of a petechiae or purpurae, and fever is present, which indicates infection, which is due to involvement of WBC line. So here you have a case where you have involvement of RBC, WBC, and platelet, and the clinical clinching point here is the presence of nocturnal pain. So what does this nocturnal pain suggest? So this nocturnal pain suggests the involvement of bone marrow, that is involvement of the periosteum. In whatever may be the case, you will not have a nocturnal pain. Nocturnal headache, nocturnal bone pain, always in favor of a malignancy. This will be useful not only for your clinical purpose as well as for your entrance based examination. So if there is nocturnal pain in the history, you consider in terms of malignancy rather than some infection or some autoimmune condition. And here they are suspecting a malignancy. And is it B cell ALL, T cell ALL, AML, neuroblastoma, and CML? So by history, you can rule out CML because it is not, this age does not fit into CML. Is it AML? Maybe. Is it neuroblastoma? Maybe. But they have given the clue, that is the marker. The cell line shows positive for PAX5. So what is our diagnosis then? Is it AML? AML usually will have a stormy presentation, and the presence of hepatosplenomegaly is not in feature of AML. Please remember, my dear friends, that main difference between an acute lymphatic leukemia and acute myeloid leukemia is the presence of hepatosplenomegaly and stormy presentation. Usually you will not have hepatosplenomegaly in case of acute myeloid leukemia. So hepatosplenomegaly is in favor of ALL. Is it neuroblastoma? Maybe, but you have given a clue, that is PAX5. So we are ruling out CML, we are ruling out AML. Is it B cell ALL, T cell ALL, or neuroblastoma? And age, look at the age. The age is 4-year-old, maybe a boy or girl. Usually T cell ALL present in older age group, that is in the adolescent male or female, whereas typical age for B cell ALL is this, that is a 4-year-old boy or girl. Is it neuroblastoma? Again, neuroblastoma is a disease of infancy. Okay, it is usually the presentation age is around 1.5 years. So we are reasonably ruling out neuroblastoma, reasonably ruling out AML, ALL, and ALL, I told you hepatosplenomegaly is less likely. CML, again, the age doesn't fit into it. So what is the PAX5? So if it is a case of ALL, one marker is common to both ALL, that is both B cell ALL and T cell ALL, which is not present in AML. What is that marker called? That marker is terminal deoxytransferase, that is TDT. TDT is present only in lymphatic cells, not in myeloid cells. So presence of TDT, that is terminal deoxytransferase, is in favor of ALL. So which is not present in our case. Now they have given the choice as PAX5. So what is PAX5 stands for? So whether which one has got PAX5? Is it B cell ALL or T cell ALL? Let us see. So you are seeing some lymphatic cells which are blastic in nature from bone marrow. Before going to the discussion, let us see something about the second case scenario. And this is a 12-year-old child has come with respiratory distress with engorged veins, neck veins and face. The diagnosis, you need to tell me now what it is. The marker is CD7 here, and I have given you the same choice. And X-ray here shows you. Here shows. Is it possible to identify for you? Yes, the lung is clear. You have a lymphatic lymphoblastic cells in the peripheral smear. Look at the nuclear cytoplasmic ratio. The nuclear cytoplasmic ratio is more. The nuclear ratio is more compared to the cytoplasm. So it is a blastic cell. Look at the X-ray. The X-ray has got widened mediastinum. Widened mediastinum is in favor of T cell ALL. I told you just before that the presentation of T cell ALL is around 12-year-old with mediastinal enlargement. So this is a case of T cell ALL depending on the age, depending on the presentation. So the first case, 4-year-old boy, bleeding, bone pain, pallor, so which is nothing but your B cell ALL. Again the second one, a 12-year-old boy with a cough, weight loss, mediastinal mass, and I told you it is T cell ALL. The typical presentation of B cell ALL I have given you. The typical example of T cell ALL I have given you. Now what is the genotype of B cell ALL? Normally you need to know, nowadays we are living in an era of markers. Okay, marker not only for your clinical purpose, prognostic purpose, but also it is very useful in entrance examination, particularly your AIMS, PGH Chandigarh, as well as your All India entrance examination. So what is the marker for? That is the genotype of B cell ALL. The marker for that is the translocation associated with the B cell ALL is 1221 translocation. I repeat, the translocation associated with B cell ALL is 1221. Leave alone the CBF alpha and ETV6, definitely you will forget it. So remember 1221 translocation is associated with the B cell ALL. Again, what is the marker for genotype of T cell ALL? It is nothing but your Notch mutations. So 1221 translocation is for B cell ALL and Notch mutation is for T cell ALL. So as a whole, what is the marker of this? I told you the lymphatic cells is positive for terminal deoxytransferase. So which is specific for T cell and which is specific for B cell? So the marker for T cell are 1, 2, 5, 7. You all aware of that. So the marker of B cell is, you know about color 19 and 10, but you should also know about PAX5. So PAX5 is a marker for B cell. 1, 2, 5, 7 is a marker of B cell. And I told you already, both has got the marker for terminal deoxytransferase. So whenever you see a lymphatic cell, a lymphoblast with increased nuclear cytoplasmic ratio, confirm with the terminal deoxytransferase. Terminal deoxytransferase is positive for lymphatic cells. To know whether it is a T cell ALL or B cell ALL, again you subclassify the marker. The presence of CD1, 2, 5, 7 is in favor of a T cell ALL, and presence of 19, 10, 5 is in favor of B cell ALL. And friends, so what is nothing? TDT is nothing but your DNA polymerase, which is positive for lymphatic cells. And very important with respect to entrance examination is, what is the most common? So I have given you ALL, B cell ALL, T cell ALL, and I have told you something about AML, in which organomegaly is less common and which is present with the stormy presentation. Now tell me, what is the most common cause for congenital leukemia, most common leukemia causing infants, most common leukemia in Down syndrome, and most common leukemia in Downs in less than 3 years? And I will give you two choices: ALL, AML. That's all. So now tell me. Yes, the most common cause for congenital leukemia is AML, and the most common cause for infant leukemia is ALL, and most common leukemia in Down syndrome, remember friends, it is ALL, but The most common leukemia in Down syndrome less than 3 years is AML, that is particularly your M7 type. Thanks friends, thanks friends. Okay, right. Oh, so with this we are going to our third question, and definitely you will have questions regarding prognostic factors. Okay, prognostic factors for ALL, AML, CML, neuroblastoma, so many things you have. Remember friends, prognostic factors are very very important, again not only for your clinical purpose but also for your entrance examination. Okay, so let's go to, so first question we dealt with B cell ALL, that is a 4-year-old boy with the organomegaly with the involvement of 3 cell line. Second one, a 12-year-old boy with the mediastinal involvement, that is T cell ALL. Okay, now let's go to the prognostic factor, that is our third question. The following are good prognostic factors in ALL. Except, okay, remember friends, don't try to mug up each and every point. You need to rule out certain points based on a simple logic. Okay, don't mug up each and every point. So the following are good prognosis in ALL, except, that is B cell ALL, female sex, trisomy 4 and 10, hyperdiploidy, male sex 411, more than 10 years, more than 50,000 count. So now tell me friends, which are the bad prognostic factors and which are all the good prognostic factor. Remember friends, definitely you and me always have some soft corner for females. In the same way, our leukemia cells also have a soft corner for females. So what I want to mean, that is female sex has got a good prognosis. One. And regarding hyperdiploidy, I want to tell you one particular point, that is hyperdiploidy is a bad prognostic factor in case of Wilms tumor. Apart from that, it has got a very good prognostic factor in many other malignancies. I repeat, hyperdiploidy is a bad prognostic factor in Wilms, but it has got a very good prognostic factor in all. And friends, and regarding age, usually the normal leukemia age is between 1 to 9 years. So less than 1 year, it is a bad prognostic factor. More than 10 years, it is a bad prognostic factor. Why it is a bad prognostic factor? Less than 1 year, it is always associated with infant leukemia, that is translocation 411 is associated with in less than 1 year. And more than 12 years, remember friends, it is usually T cell ALL. So T cell ALL has got a bad prognostic factor compared to B cell ALL, and I told you T cell ALL is usually occurs in males. So let us and also about WBC count more than 50,000 cubic millimeter. So what is your inference regarding that? And I told you, more the count, poor the prognosis is. The massive the number of blast cells, definitely you have a very bad prognosis. So I told you age between 1 to 9 years, good prognosis. B cell ALL, good prognosis. Total lymphocyte count, lesser the count, good prognosis. Female like you and me has got a good prognosis. I told you about hyperdiploidy, it has got a good prognostic factor. Trisomies has got a good prognostic factor. And remember friends, the response to prednisolone also should be taken into account. Prednisolone response, you give prednisolone for about 7 days and you check the count, and if the count is less than 1000 following 7 days of prednisolone, it has got a good prognosis. And regarding bad prognosis, I told you age less than 1 year and more than 9 years. T cell ALL, I am sorry, lymphocyte count more than 50,000, it is wrong here, it is more than 50,000 is a bad prognostic factor. Hypodiploidy is a bad prognostic factor. Male sex is a bad prognostic factor. And remember friends, this translocation 922 may be a good prognostic factor in CML in case of adult, but is a very bad prognostic factor in children. And translocation 814 also associated with a bad prognostic factor, and also your 411 has got a bad prognostic factor. So mediastinal and CNS involvement, which I told you, which occurs usually in older age group, that is more than 12 years. Remember, this is very important, and a minimal correction here. T cell count more than 50,000 has got good prognostic, bad prognostic factor.